Assalamu alaikum, it's me Dr. Naseem Shirzad, and today I'm going to discuss with you all the horseshoe kidney. So, by definition, the horseshoe kidney is actually a two functioning kidney that is connected at the lower fold by an isthmus, which may be a functioning parenchyma or just a fibrous tissue, and that it make it look like a U-shaped or horseshoe kidney. So actually, there are two moieties that are connected with each other by isthmus. Now, this isthmus may be functional or this may be non-functioning. I means this isthmus by which the two moieties are connected, it may be containing a functioning tissue or it may be just a band of fibrous tissue, and it is take its blood supply either from the renal artery or directly from the aorta. The incidence of horseshoe kidney is 1 ratio 400 or 1 and 500, and the variation include that the lower pole fusion occur in 95%, upper pole fusion can also occur. But what important that why is this fusion is occurring? This is occurring because of the fusion of the metanephric tissue during early gestation. So the actual embryology behind this horseshoe kidney is due to the fusion of the metanephric tissue during early gestation, that leading to the fusion of the lower fold of the kidney, and this lead to the subsequent arrest of these fused lower fold isthmus by the inferior mesenteric artery, that resulting in incomplete sepal migration of the kidney and associated malnutrition of the kidney. So the main embryology is the fusion of metanephric tissue during early uh, gestation and not the inferior mesenteric artery. Inferior mesenteric is present in every one, but that not causing the actually this horseshoe kidney. The horseshoe kidney is caused by metanephric tissue. Inferior mesenteric artery only arrests the sepal ascent of the kidney. And generally, the isthmus is bulky and consists of parenchymatous tissue with its own blood supply. As we also mentioned that it may be directly from the aorta or from the renal arteries, and sometime it may be a fibrous tissue or vein. The isthmus of this kidney is located at L3 L4 vertebral level, just below the origin of inferior mesenteric artery from the aorta, resulting in a paired kidney lying lower than the normal position. And it's also important to mention that its association with the other anomalies. The extragenitourinary anomalies include most commonly affected organ is skeletal system versus CNS and CNS CVS system, and found in 3% of all neural tube defects. And in rectal malformation patient, 20% of the trisomy 18, which called the Edward syndrome, and in 60% patient of the Turner syndrome. So the association this extra genitourinary, and now its association is also present with some genitourinary anomalies like hypospadias and UTT in 4% of cases, urethral duplication, ectopic urethrocoel, VUR, POJO. So it's important that association with the stone formation and POJO is 20%, as it asked multiple times in exam. So the association with POJO and stone formation, that is 20%. And as usual, the investigation include the plain abdominal radiograph and kidney somewhat low lying and close to the vertebral column, as I have already given multiple picture with in one there is no connection of the isthmus. The isthmus is not fibrous and that's why it's not visible, just lower lying kidney with ureter arising from the lateral fold. One of the important thing is that how is the kidney structure arrangement. Actually, the calyces are normal in number, but that are atypical in orientation. Like it is lies most posteriorly due to failure of the rotation of the kidney. As kidney is not properly rotated because of this inferior mesenteric artery, so the calyceal are more pointed to posteriorly, and the ureter is inserted high and it is inserted lateral into the pelvis and is a characteristic bend as it crosses over the interior to the isthmus. That's why it's predisposed the kidney into stone formation and POJO. And the other investigation for this is the retinucleate scan that will be showing two moiety with band in between. We can also go for CT and MRU, and the MR angiography can be done to properly document the vascular anatomy for preoperative planning. Now the calculus formation in horseshoe kidney, 20% patient having this problem, and the earlier hypothesis was that the calculus formation is due to the higher rate of infection, stasis and obstruction because of abnormal position of the pelvis and ureter. But now it suggests that the combined anatomic and metabolic causes leading to the formation of these stones like hypovolemia, hypercalciuria, hyposteaturia, and these are the most common metabolic defect. The most common stone type in as in other type of kidney, same in horseshoe kidney, and that is calcium oxalate stone. Now the treatment of these stone like the ESWL to treat stone in horseshoe kidney, the favorable factor for ESWL in horseshoe kidney, a stone burden less than 1.5 centimeter, and that should be non-obstructed collecting system drainage. Anomalous kidney orientation make localization of these stone more difficult, especially for stone in anteromedial calyces. So prone position may facilitate the localization of this stone. And alternatively, a blast part technique may be employed. Also, it may interfere with fragment passage after the ESWL. And the clearance rate for lower calyceal stone was inferior to that of middle and upper calyceal stone, that's for horseshoe kidney and also for other kidney. And a high number of shock waves per treatment required and higher retreatment rate is observed. The other option is the RIRS to treat calculi in horseshoe kidney, and that the ureteroscope may be an effective treatment modality for a stone if it is more than 1.5 centimeter in horseshoe kidney. And we can use laser with the help of flexible URS, and will be removing that with the help of Netanyahu grasper or ureteral access sheet. Chemical implication of horseshoe kidney and PCNL. So the anterior-posterior tract of the kidney is prominent, which make upper pole the most superficial and posterior aspect of the horseshoe kidney. That's why our main target in horseshoe kidney is that to target the upper pole, and that is the posterior pole, like that's shown in a picture. In horseshoe kidney, the frontal plane lies more or less in the sagittal plane of the body. So consequently, posterior row of calyces point dorsomedially and ventral lobe dorsolaterally, and the renal pelvis is in a ventral position. So in normal kidney anatomy, the upper pole calyces are in front of L1 and 2 ribs. Entering them need a supracostal approach, but luckily in horseshoe kidney, the kidney is low-lying, so there is no need for any supracostal approach in case of horseshoe kidney. And the optimal point of entry is already mentioned, that the posterior calyx and upper pole, which is typically more medial than the normal kidney because of altered renal axis and rotation associated with midline fusion. And initial entry to the horseshoe kidney is more medial than the normal kidney and can pass through the paraspinous musculature, and slightly more difficult to dilate because that transfers through the erector spina and quadratus lumbrum muscle. And this is the retrograde film. And the vasculature of the horseshoe kidney is aberrant, but vessel enter and exit the kidney in anteromedial location except for some of at the isthmus. So direct vessel injury is rare as compared with the normal kidney with well-flanked axis, as puncture of the dorsal or dorsolateral aspect of the kidney will be well away from the major renal vessel. However, direct access to the isthmus calyces are not suggested because separate vessel may be present and that can lead to bleeding. And the standard site for PCNL puncture along the posterior axillary line just caudal to the 12th rib means subcostal but angled caudal rather than sepaled. This provides percutaneous access to upper pole posterior calyx, and this is useful in horseshoe kidney because this is the easiest calyx to enter. Puncture is subcostal and provide excellent access to the most of the kidney indurator owing to the alignment of the long axis. So this is the benefit of but the tract are usually longer as the kidney is low lying and the renal pelvis may be more interiorly located. In such cases, flexible nephroskope or longer rigid nephroskope may be needed. So this was all about the horseshoe kidney.